It is my pleasure to introduce Professor Yair Reizner, who will be the keynote speaker for this first alpha-beta T-cell depleted transplantation symposium. Dr. Reizner has been central to the development of haploidentical transplantation for more than 40 years. After finishing his PhD at the Weizmann Institute, he moved to Memorial Sloan Kettering, where he perfected his T-cell depletion techniques, which resulted in the first successful T-cell depleted haploidentical transplant for a patient with severe combined immune deficiency. After his return to the Weizmann, he demonstrated the need for megadoses of hematopoietic stem cells to ensure engraftment in the haploidentical setting. These two principles, the effective T-cell depletion and the need for megadose stem cells, are the keystone for haploidentical transplantation. It is fair to say that Professor Reizner is the godfather of haploidentical transplantation. Therefore, I'm looking forward to hearing Professor Reizner's keynote address on the evolution of T-cell depletion. Welcome, Dr. Reizner.
Thank you, Robbie, so much for your kind words and for your friendship over 4 decades. Just try to connect. I am talking from Israel as I'm now in vacation here, but it's great pleasure to be virtually in Stanford. Since our first meeting in the Red Sea in Eilat in 1999, Massimo Martelli and I have had the pleasure of organizing 9 times this international haploidentical symposia. And we are very appreciative and thankful for the organizer, Dr. Betania and Maria Grazia and all the others of this outstanding meeting, despite all the issues of COVID. Furthermore, I'm very thankful to Maria Grazia and the organizers for the opportunity to review the evolution of T-cell depletion, which spans a good part of my career and personal life, from the early days in the late 70s at Sloan Kettering, thereafter the long period of my tenure at Weizmann Institute, and finally my more recent days as of 2018 in Houston, where we ran a clinical trial testing the safety and efficacy of our Veto cells in humans, in patients. As GVHD represents a first barrier in the haploidentical setting, it was only natural that great efforts to use T-cell depletion were focused over the years on this challenge. So basically, I will limit my talk to the major milestones in T-cell depleted haploidentical transplantation, starting with the success in SCID patients during the 80s, thereafter the difficulties of engraftment and the role of megadose transplants in leukemia patients during the 90s, followed by the more recent improvements, including alpha-beta depletion, and finally, the current efforts to achieve engraftment without GVHD in non-myeloablative T-cell depleted haplotransplants. Over the years, we were fortunate that many distinguished scientists and clinicians joined this effort. And although I will mention a good number of these dear colleagues, I apologize for those who I failed to mention in this brief review. The understanding that GVHD can be prevented by T-cell depletion goes back to the late 50s of the last century, namely the seminal studies of Ursula Ophoff, who suggested that fetal liver, in which the number of T cells is reduced compared to the levels found in the bone marrow, can be used compared to avoid graft-versus-host disease in lethally irradiated mice. This indirect approach for T-cell depletion was subsequently also used by Eunice from Harvard, who used thymectomized mice to achieve adequate T-cell depletion in vivo. However, the first definitive demonstration of T-cell depletion ex vivo was shown by von Boehmer, Sprant et al. In 1975 using the anti-Taiwan antibody or theta antibody plus complement. And the first successful implementation of T-cell depletion, as mentioned by Robbie, in the treatment of SCID was achieved in 1980 using the lectin approach that we developed in 78. The lectin option originated from my PhD thesis with Nathan Sharon at the Biophysics Department in Weizmann Institute. Working on lectin receptors, we found surprisingly that during T-cell maturation in the thymus, there is a gradual addition of sialic acid to the elongating sugar chains on glycoproteins, leading to loss of binding to the peanut lectin or the soybean lectin, which can only bind to the unmasked per ultimate galactose moieties. Thus, we found that mature T cells can be removed from the bone marrow stem cells by differential agglutination of the stem cells on a viscous medium, such as 5% solution of BSA. The aggregated cells, including the stem cell, can then be dissociated into single cells by washing with the inhibitor of the soybean lectin, D-galactose. And this separated T-cell depleted stem cell preparation could effectively engraft in mismatched recipients without GVHD. Upon this finding, we submitted this paper to PNAS, and it so happened in 78 that Dr. Bob Good, at that time the president of Sloan Kettering, was the reviewer of the paper. And so he got excited about this option. He called me and asked me to join them at Sloan Kettering, where they had on the 5th floor several bubble children in the bubbles. And upon my arrival in 78, he introduced me to Dr. Richard O'Reilly. At that time, he looked much younger, of course, who was at that time running the bone marrow transplant service with Dr. Good. And we had great friendship, and we worked very hard with many ups and downs, which took us about 2 years. And the reason for these ups and downs was that very early on, I found out that, as might be expected, lectin receptor expression on the human bone marrow is different from mouse. And it so happened that actually the stem cells are not binding to the soybean lectin and can stay on the top of the gradient, while the majority of T cells are agglutinated very rapidly and can be sedimented and removed very rapidly. However, it was not as easy as with the mouse because there was a minor subpopulation of T cells which was not agglutinated, and to remove them, we used the classical erosetting technique, a very old one. And obviously, the FDA would never allow this use of sheep-fed blood cells, but you use it hundreds of times. And so by middle of 1980, we were ready for our first transplant. And it was this beautiful baby, and who got his bone marrow from his mother. I should say that we managed to get 3-log depletion by this approach, which is very important for avoiding graft-versus-host disease. And also we saw in this baby for the first time immune tolerance as we know it in mice, in that the mother T cells, which before transplant, of course, were reactive against the patient, lost completely the ability to respond against the patient, but did not lose the ability to respond against the father haplotype, which is a perfect tolerance. Then we went on and did 2 more successful transplant in 2 more babies. And I would like to mention at this point Nina Kapoor, who was part of all the methodology preparation and the fractionations and also the treatment of the children. And so anyhow, by the end, by 83, we published this first experience in Blood, in this paper in Blood. I'm sorry. And I went back to the Weizmann Institute again. I joined the faculty there. But on my way to Israel, I was happy to accept an invitation from my friend William Friedrich in Ulm, who had a large unit also. And in this paper that you see here, we actually show data from 11 successive transplant in SCID patients. But we did the first one together. I demonstrated the methodology in Ulm. And then, interestingly, this very first patient was followed by Ricky Prism from the Weizmann Institute, who made a film, a movie on this baby for many years. She followed him for many years. And this movie won many awards in film festivals. Just show you a few pictures. This is the boy here at age of 12, I think, and then his wedding, then his first child. So nice anecdotes and a nice movie. But clearly, we need more than anecdotes like that. And the experience in SCID patients was published by many centers around the world, but largely by the Sloan Kettering group, of course, with Richard O'Reilly. You can see the numbers here and the very long follow-up and the outcomes, and also by Rebecca Buckley, who is a real a leader in this field, who published a lot on this methodology in these patients. But interestingly, we now know that the outcome can be even further improved if the patients are transplanted early on before severe infection takes place. Outcome of such haploidentical transplants were found to be similar to those obtained with matched sibling donor, as you can see in this New England Journal of Medicine paper. Then the growing experience with T-cell depleted grafts during the early 80s has led to the application of this approach also in the treatment of some of the Chernobyl victims that were sent for transplantation in hospital number 6 in Moscow. These episodes, which was covered extensively in April 86 by the media, was led by Bob Gale and his colleagues, Champlin and Terasaki from UCLA. Bob Gale invited me to join this adventure, although at that time, in the heights of the Cold War, there were no diplomatic relationship between Israel and the Soviet Union. And my entry to Moscow required special intervention of the Soviet and the Israeli governments. Altogether, we treated 10 firemen that were exposed to lethal radiation. For 6 of them, Terasaki was able to find matched donors, but for the other 4, we applied T-cell depleted haploidentical transplant. Last year, upon the broadcasting of the Chernobyl TV series, I was asked to write my memories from this special experience for Time magazine, which was based on notes which I wrote daily during my 10 days in Moscow. Here you can see the small lab that we set there with supplies that was sent from Sloan Kettering, from Richard O'Reilly. And here you can see my farewell lecture. To the right, you can see the late Dr. Baranov, who's a great hematologist and a great expert in radiation biology. After many years, I was delighted to host him at the Weizmann Institute and learn a lot more on episodes that happened behind the scene in Moscow while we were doing our transplants. The entire clinical experience was published in 1988 in the New England Journal of Medicine. Taking together, out of the 10, only 2 survived, and those were the recipients of T-cell depleted haplotransplant. The 6 recipients of unseparated matched transplant died with many complications, including GVHD. Although these are very small numbers, I think most of us agree now that any risk for GVHD in such patients, especially those suffering from skin burns, is problematic. But clearly, the major potential use of T-cell depleted haplotransplant is in the context of leukemia patients. But very early on in the 80s, we learned at Sloan Kettering that despite the supralethal conditioning, some persisting anti-donor immune cells, as well as some form of stem cell competition, posed high risk for engraftment failure. Thus, we had to return to the mouse models, and it took a good number of years to find in '89 that perhaps the easiest way to overcome rejection could be afforded by the use of megadose transplants. We also learned in these models that addition of tiotepa to the conditioning could synergize with the megadose approach in overcoming the stem cell competition issue. Based on these insights, we began in '93 the clinical translation of megadose T-depleted transplant together with Massimo Martelli group in Perugia. This long-term successful collaboration led to a great friendship and many trips together. Here, for example, is our first meeting in Eilat. We organized a trip to Petra. Maybe some of you remember, a beautiful place, and also in Capri. We published many papers in this. It's now deep in the clinic, but I think the most important publication and the early ones were the one in Nature Medicine and the one in Immunology Today. Also, very important, of course, was the study of Franco Aversa, published in Blood in '94, and then in the New England Journal of Medicine in '98. I should say that we've done so many transplants in Perugia, so I think it's enough to show this data from Franco Aversa and Martelli. Here you can see engraftment was fine. We overcome the problem of rejection with very little problem risk of acute or chronic graft-versus-host disease. And I should mention that this was without any post-transplant immune suppression, which is very important to emphasize. You can also see the outcome in more than 250 patients. In AML, very good results, especially in CR1. And of course, they are less good in patients in CR2 or relapse. And similar outcomes were also reported by the EDMT survey. But I should say, also anecdote, I show you another anecdote, I'm sorry for that, but it's very personal for me. This is the 10th anniversary of the group in Perugia, when many of the patients came to this meeting and were very eager to share the very moving experiences. Now, despite this success in the late 90s, I should say, of overcoming graft rejection without graft-versus-host disease, we still knew that we can improve the outcomes because there was a problem of immune reconstitution in this patient, which is very slow, and we believe that it can be improved. The reason for the slow immune reconstitution is obvious. The thymic function is extremely poor, especially in elderly patients after chemotherapy. And it takes about 6 months to 1 year to achieve output from the thymus. And so the immunity depends largely on the T cells, which we adaptively infused. And because we want to avoid graft-versus-host disease, this was very small numbers. And the patient had a marked risk for developing infection during the first 3-4 months post-transplant. And this issue, how to improve immune reconstitution, was the center of the recent haploidentical stem cell transplantation meeting in Israel before COVID. So this was almost the last one. I think it was the last time, and I'm very glad that now you have your own meeting. And so anyhow, what came out from this meeting was clearly two approaches for adaptive transfer of broad immunity. One is the topic of the meeting today, alpha beta depletion by Gretinger, of course, and by Locatelli and many others now that we hear in the meeting, so I will not talk much about it. And the second approach, which was pioneered really by Rob Negrin in Stanford and followed into the clinic by Massimo Martelli and his colleagues, was the use of Tregs to prevent GVHD that might be caused by adaptive transfer of normal T cells. And so basically, this is the seminal paper that I'm sure all of you know by Rob Negrin and his group, who showed the concept that you can add unseparated T cells if you combine them with T regulatory cells, and you can retain graft versus leukemia activity without having marked graft versus host disease. And as I said, this was translated into the clinic by Massimo Martelli as early as 2011. Here again, they give the conditioning that we always used for haploidentical transplant, and they give the Tregs 4 days before the megadose stem cell transplant, plus 1 million of T-cons, as we call them, the conventional T cells. And very recently, this approach was even improved to some extent by Pierini et al., who showed that it can include in this AML cohort of patients elderly people above age of 50 by using for these elderly patients myeloid radiation, mirror radiation, TMI, and lymph node radiation. And just to show you, these are the number. They did like 50 patients. As you can see here, 31 were above age of 50. And for them, they got this TMI radiation, while the younger people got TBI. And again, this is, they don't avoid completely graft versus host disease, but mainly chronic graft versus host disease is very low. And in the patients which have no problems of graft versus host disease, they find a very fast immune reconstitution thanks to the adaptive transfer of normal T cells. And a similar finding was also shown for B cell function, as shown here. And the bottom line, which is very exciting, is that in these 50 patients, including many elderly patients, they achieved 75% chronic graft versus host disease-free, relapse-free survival. Okay, and now for the last part of my talk, addressing our present efforts to achieve engraftment of T-cell depleted haplotransplant in patients conditioned with a minimal non-myeloablative protocol. Clearly, this is very important for elderly patients who cannot tolerate the harsh conditioning. It is also very good for hematological, for non-malignant hematological diseases where you don't want to use high doses of radiation, or as a protocol for cell therapy in organ transplantation, where any risk for graft versus host disease is unacceptable. Now, as we all know, the use of non-myeloablative protocols has been around for many years. And so, but with one caveat, usually people use a T-replete transplant, like the Johns Hopkins group and many others. And these tons of T cells which you give to the patients have a lot of alloreactive T cells that can pave the way for engraftment, obviously, to attack the host. But this is at the expense of graft versus host disease, of risk for graft versus host disease. So the big question, the big challenge is to do it without these T cells in the graft. Obviously, when you do less conditioning, you have most anti-donor immunity. And we found very early on that the megadose CD34 cells cannot overcome this huge barrier. And so our approach is to use these megadose transplant in combination with Veto cells. And I'll explain now this concept. Our interest in Veto concept, in the Veto concept, started when we looked for the mechanism of action of the megadose transplant. We wanted to understand how is it that CD34 cells can evade the attack of a cytotoxic T cell. It's not trivial. And after a lot of studies, we found that CD34 cells exhibit a Veto activity, which is mediated, by the way, by TNF alpha. But if you're interested, you can look in blood for the mechanism. Now, the Veto concept was coined by Miller already in 1980 in a seminal paper where in Nature, where he showed that upon the recognition of class 1 peptide on the Veto cell by the T cell receptor of the recognizing T cells and the formation of a synapse, instead of the usual activation and differentiation of the recognizing T cell, this interlude with the Veto cell lead to the demise of the recognizing cognate T cell. And when you infuse, and when you look under the microscope, you can see it very nicely. Here we have two TCR transgenic mouse T cells in green that bind and attack a Veto cell in orange. And as you can see, this interlude leads to the death of the first TCR transgenic T cell, and in a second, you see the other one will die, while the Veto cell itself survived this attack and can go for another round of killing, which makes it very effective in vitro. It works at a ratio of 1 to 20, 1 to 50. And when you infuse Veto cells into a recipient, only the clones which recognize the Veto, the MHC of the Veto cell will be recruited and killed while all the other clones, including the important antipathogen clones, will be spared. And this selectivity of immune suppression, of course, was extremely attractive in the 80s. And so many good scientists joined this topic and did work on this, including Ramanzi in Germany and Bevan and many others. But the problem was that you could never translate it to the clinic because they didn't know how to separate this activity of T cells from GVH. Now, it is very important to understand that I'm having a problem here with that. It is very important to understand that the Veto definition is, it's a functional definition. It's not a phenotype, because we and others found different types of cells with Veto activity in our body. I mentioned CD34 cells, and more recently, we found these perforin immature dendritic cells, and so on. And but all these cells have one thing in common. the mechanism of action of all these Veto cells is mediated by deletion-based mechanism, namely by DES molecules, including phospholigand for CD8 T cells, and I mentioned TNF-alpha for stem cells, and also perforin for immature dendritic cells. Just to show you how we know these things, how we learn the mechanism, is basically using knockout mice. In this system, for example, we use C57 black host, and we use T-depleted bone marrow of bulb. And you can see with following 6th grade TBI, there is no acceptance, no chimerism, full rejection. But when we add the Veto cells, we get beautiful chimerism. So they work. And then if we use knockout mice recipients that are fast knockout, we lose completely the ability to generate Veto cells. And we also showed this with LPR, with knockout of fast ligand. And so, sorry. And so basically, we could, after a lot of work with different inhibitory molecules and knockout mice and so on, we drew this scheme for the CD8 Veto cells. Fast ligand is indeed extremely important. It's a prerequisite for generating apoptosis in the effector cell, but it's not enough because effector cells are protected from apoptosis by inhibitory molecules like XYAP, for example. So the first step, important step really, is this interaction of the CD8 molecule on the Veto cell with the alpha-3 domain of MHC class 1 in the effector cell. And this we found, of course, by inhibitory molecules. And once this is happening, you have the signaling through MEC-ERK to block XYAP. And once XYAP is blocked, you can trigger the phospholigand kill. Just an example of a complicated mechanism. Anyhow, for practical purposes, we know for a long time that the CD8 T cell is probably the best Veto cells, but they're also associated with graft-versus-host disease, as I mentioned. And so how to separate the good from the bad took some time. And in this paper in Blood, in 2013, we have shown that it is possible to achieve this goal. Basically, what we do is we separate the CD8 T cells from the spleen, let's say, and then we interact them under cytokine deprivation with stimulators from third party, which is not cross-reactive with the intended host. And so during this culture, only the clones which make IL-2 or other cytokines can survive the starvation, while other clones, including the anti-host clone that can cause graft-versus-host disease, will die by neglect. And then after 6 days of this culture, we need to get a large number of cells for transplantation. So we add IL-15 because we want central memory phenotype, and we grow the cells in large number. And then when they expand against the third party stimulation, they dilute again those that are not stimulated, which include the GVHD producing T cells. So in total, we get 3-log depletion by 2 steps. One is the selective expansion of anti-third party clones, diluting the others. And the other one is the beginning of the culture where we have death by neglect, also important. Now, over the years, we tested the Veto cells in many preclinical models, including the one for organ transplantation, which I show in a minute. Also in a sickle cell disease, we have the Berkeley model, and we just published a long-term rescue of the disease. And very recently also for autoimmune diabetes, where we showed that we actually changed completely the T cell repertoire in NOD mice, and we measured this by TCR sequencing. We showed that we get rid of the autoimmune clones. But anyhow, I think that the best model to visualize the Veto activity is in this model where we use TCR transgenic 2C cells that recognize H2D, and they can be decorated with luciferase. And so if we give the bone marrow into these mice, you see a small signal of anti-donor T cells, which grows extensively in few days after the transplant until they completely reject the bone marrow. The signal obviously is very large. But when we add the Veto cells here, we curtail the signal of anti-donor T cells until they're completely deleted. And then we have very nice engraftment. This is, of course, an artificial model. We've done it in a normal mice. Here you see biopsy mice irradiated with 5.5 grade TBI, no engraftment at all. And then when we add the Veto cells, very nice chimerism without any sign of GVHD measured by weight. And when you have such chimerism, you also see nice tolerance for skin grafting. You can see here the black skin on one side of the mouse is accepted, while we put on the other side of the mouse C2H skin, it is rejected. So it's perfect specific tolerance. And as a matter of fact, we are trying now to take this to the clinic in Houston with a Methodist group of kidney transplanters. But really the pioneers were in Stanford, Sam Stover, of course, and also others like Megan Sykes, and we should mention them. Now, a few years ago, we started a translation to the clinic of the Veto concept, and this work was largely made by Esti Bahar in my group, together with the E.J. Spal and her fantastic GMP group. And basically, it's the same, but with one major change, in that the stimulators, the third-party stimulators, which are easy to find in mice and very difficult to find in human, we don't take anymore third-party MHC stimulators, we take viruses as third-party stimulators. And so we use libraries of viruses I'll show in a minute. And in this way, we can hit two birds in one stone. We have a cell now that has a Veto activity, can induce tolerance, and for the same money, it can also provide the patient with antiviral activity. And so basically, to that end, we have to start with the memory pool, because only memory CD8 T cells are able to respond effectively to viruses. And we choose usually the donor is very easy to find, either a CMV positive donor or a EBV positive donor, which we always find. And we stimulate them again against a cocktail libraries of 4 different types of peptides, CMV, EBV, adeno, and BK, all the enemies of bone marrow transplantations. And this is after 12 days of culture, we get huge number of cells. We get enough to transplant 50 patients. And this is very homogeneous phenotype. We try to get a central memory phenotype because of what we learned in mouse. And so this is the phenotype. And actually the FDA demands that we have more than 30% of this phenotype in the cell prep. We always have more than 70%. And for every donor, we can always check the antiviral activity before transplant. And as you can see, this is one donor with a very nice activity for EBV, low activity for CMV, and also very high for adeno. But this changes from one donor to another. And this is perhaps the most important slide for the FDA, because this slide showed that we get more than 3-log depletion of alloreactivity as measured by limiting dilution analysis. We have a very elaborate test. It takes a long time, but it's very accurate. But still, obviously, we needed to find whether we have any risk for GVHD in patients. And to that end, we started this phase 1/2 clinical trial in MD Anderson together with Dick Champion, with whom I worked for so many years, since the Chernobyl days. And so this is open for many types of hematological malignancies, but also very importantly for sickle cell disease, which we hope to do in the near future. So the protocol is very well tolerated. It's very mild. It's ATG, fludarabine, trigger-grade TBI, a megadose of CD3, CD19 depleted stem cells, and then cyclophosphamide on day 3 and 4. And the reason we use cyclophosphamide here is not to avoid GVHD, because there's no risk for GVHD with the number of T cells that we infuse here, but rather we found in mice that, and we published this, that they synergize very nicely with the Veto cells and the megadose stem cells. So we like to include it in the protocol. And finally, on day 7, we give these Veto cells. In this phase 1/2 safety trial, the plan was to start dosing the first cohort of 3 patients with 5 million Veto cells per kilogram. And if we find graft rejection, to increase the cell dose to 10 million. On the other hand, if we find grade 3/4 GVHD, to reduce the dose to 2.5 million. So far in 6 patients, the dose of 5 million seems very safe. And we continue with this dose. We have engraftment, we have no GVHD at all, and so we don't change the dose so far. And so to finalize, if the safety profile of our protocol will continue in the next few patients, we plan to start using the protocol in patients with sickle disease, as I mentioned. Also, together with Dr. Gaber in Methodist, we should start using this protocol as a platform of immune tolerance induction in kidney recipients, just like what was done by Sam Storber and Sanford, instead that we have, I think, a less risk for graft rejection. For patients with high-risk hematological malignancies, we find it possible in preclinical studies to arm the Veto cells with appropriate CAR, so as to attain in one cell type Veto activity, antiviral activity, and graft versus leukemia activity. But this is still for the future. Finally, our preclinical data also suggests the potential use of Veto CAR out of the context of bone marrow transplantation for off-the-shelf CAR T-cell therapy based on the ability of the Veto cells to evade rejection. We have published on that, but we have no time to go in detail about this. And last but not least, I would like to thank so many people that worked with me over the years in Israel and in around the world. I mentioned, of course, Robert Good and Richard O'Reilly, Franco Aversa, a very, very close friend, Massimo Martelli and his group. Also, more recently, Hermann Einzelli and Matthias in Würzburg. And last but not least, Richard Champlin and E.J. Spal, who worked with me beautifully here in MD Anderson. And in my own group, I mentioned Esti Bahar, who did a lot of who worked with me for almost 30 years now, all the work in mouse and human, and also many other students, excellent students. For example, Noga, who is now in Stanford, you should know her. I mean, she did a lot of work on the mouse models, on the Veto cells. And also I mentioned Asaf Lask, who did a lot of the work on the Veto human cells. Thank you very much. Thank you.
As usual, a great talk.
Thank you.
The thing that was most exciting was your last bit. You want to say a little bit more about how Veto cells being stimulated with CARs has some anti-leukemic activity?
Sure. I don't have the slides here because I didn't plan to show it, but I can tell you that it's very straightforward. These are, as you saw, these are CD8 central memory cells with antiviral activity. So they answer all the requirement of good Veto cells in the mouse model. And we transduce them here very easily because they're activated in culture. So it's very easy to transduce them with retroviral vectors And so far, the preliminary results show that they work very effectively against CD19 targets, for example. And so now we need to get a vector that is GMP grade. It's always a problem in order to go to the clinic. And we just have it now. And so I hope that in few months, if we show the same kind of level of safety on efficacy in the mouse model, that we started here in Houston.
So I understand, because originally I thought it was that the cars were stimulating the veto cells rather than the veto cells being made as cars. I understand.
Okay. Yes. So no, we just add them during the culture. We transduce. It's very easy to transduce them with CAR.
Can I ask a question?
Of course. Hi, Maria.
So yeah. First of all, beautiful. As usual, you gave a fantastic talk. So I have a more general question about the future and also a specific question. So the question about the future, being at Stanford, the Stem Cell Institute, where Herb Weizmann discovered the purified the real blood stem cells, as he always says, CD19, CD34 positive. And he claims that, and he showed actually that in the mouse, when you give these purified stem cells, you have a better immunoreconstitution because you don't have all the contaminants that are in the CD34 positive pool. So do you think that this would be a possible way to go in combination with the therapy to accelerate immune reconstitution? So this is my first question. The second question is related to the Veto cells, which are totally fascinated. So number one, do cytokines play any role in this Veto activity? And number two, is the class 1 signaling on the target cells the key event? Or the key event is the TCR recognition by the target cells?
Yes, these are very good two questions, Maria. I start first with the first one, right? I don't know what to answer you because I don't have experience with immune reconstitution using those stem cells. I think it's on Earth role to show it, right? And maybe I don't know if it will work with human or not. As a matter of fact, I find, our early studies in mice were done with T-depleted bone marrow, not with stem cell purified bone marrow. Like many others, and with the lectin, we did a lot of work. It's always, you don't remove NK cells that are there in the graft. You don't remove other cells, like early myeloid and God knows what. Only the T cells, and we did not see any issues. Actually, the truth is that CD34 selection arrived first by Milteni. And so Massimo Martelli began to use the CD34 selection because the lectin approach or method is very cumbersome. They did a lot. They did 36 patients out of the 250, but they were very glad to get rid of the lectin and do the thanks to Milteni and Rupert and all the other colleagues. I think they happily endorsed the CD34 selection. I feel more comfortable personally with alpha beta or with even CD19. You saw that we use CD3, CD19 now in MD Anderson. This is because we retain the NK cells, which I think are very important for engraftment and are very important for the patient. And so I prefer T-cell depletion to CD34 selection in general. Now, the problem of immune reconstitution really was the worst because we use CD34 selection. And so because we don't give any other cell, not NK cells, not gamma delta, nothing. And I think there is a good promise Now by the Stanford group, of course, by Locatelli, by all these people, I think they use alpha-beta depletion. It makes sense because you want to give the patient adaptive transfer of as much as you can of immunity. Now, also, don't forget that mice are more easy than humans. And so the thymus is in good shape in black mice, but in our patient, it's really in bad shape. And so it's very hard to translate from mouse to human immune reconstitution, where you don't have a very good output of the thymus, and you depend completely on what you give in the adaptive transfer in the bone marrow. So this is my answer, but I really don't know it has to be shown. It has to be shown. Now, the second question, it's a very good question. Remember, it's a kind of a passive aggressive mode, the Veto function. They don't do anything until you attack them. And so the first step is the recognition by the TCR of the anti-donor host T cell. This is the first to go. And they form the synapse between them. And then you see the lesion under your eyes. So it's not a cytokine, it's not like Tregs where you, or your TNR1 cells and so on with IL-10 and all that. It's always the lesion that is made, and you can actually, we published this and you can see it. I didn't have time to show it. By using the 2C model, you probably know this model, the transgenic, the TCR transgenic model, where you have a transgene anti-H2D, okay? You can actually see the conjugates under your eyes. You can see annexin developing in the cognate T cell by FACS, because you can decorate the 2C cell, the recognizing cell, and the Veto cell with the H2D expression, and you can see how they induce the annexin in the recognizing T cells and how the cells die out. So it's very much apoptosis mediated and deletion, as opposed to Tregs or TR1 and so on, which seems to be also mediated by cytokines.
Thank you. Thank you, Yair.